In today's video, we have a masterclass on shoulder instability, a guide for physical therapists. What's going on, guys? This is Dan from Fitness Pain Free. I'm a physical therapist and a strength coach. My partner in crime, Kevin Coughlin, is also a physical therapist. And we've helped to make thousands of incredible clinicians through our online communities, courses, and programs. In today's video, we're going to help you become 1% better. All right, so this master class is broken into 4 different topics. The first is going to be what physical therapists need to know about shoulder instability. We give you all the basics about understanding shoulder instability. After that, we go into surgery versus physical therapy for this common condition. When a patient walks through the door, dislocated the shoulder, what should you do? Physical therapy, surgery, what are the pros and cons of each? After that, we go over principles of non-operative physical therapy treatment. Basically, if you're going to start your physical therapy with this patient, what are you going to do? And lastly, 6 keys to shoulder instability physical therapy, where we give some practical recommendations to make you a better coach and clinician. Enjoy. What physical therapists need to know about shoulder instability.
So this first episode, we're talking about kind of what PTs need to know about shoulder instability and just some kind of background terminology. And, I know when I was first learning about this, there's a lot of terms that are confusing and, there's different types of shoulder instability. So I thought it would be helpful to just orient people to the topic a little bit and then, some links to articles that they could check out as well, just to learn more.
Yeah, I agree with you. I think that when I was in PT school, and PT school, it's not meant to prepare you thoroughly for everything. It's supposed to be just like a very brief understanding of a lot of different topics. But when I started practicing, I think I didn't know enough about this topic. And I think I made some wrong decisions. I think you were talking previously in the episode of the rotator cuff, where you're like, "Oh, I had this guy who built a whole chicken coop right after he had a rotator cuff repair." And I was like, kind of my fault. I wish I had educated him a little bit better. Right. Which at the end of the day, who knows, right? Is that really your fault? But I think for myself too, I've had a bunch of these, especially traumatic instability events with patients. And I think as physical therapists, we're almost always thinking, all right, let's try conservative care. Let's do our best. Sometimes that's not the best choice. And we'll talk about more about it in these next few podcasts. But I agree with you. I think this is going to be really illuminating. And if you don't get this right, you could potentially set your patient up to be in a bad spot long term, unfortunately.
Totally. Yeah. So just starting off, some quick definition. So, what do we mean when we talk about instability? With the shoulder, generally there's a soft tissue or bony insult that causes the humeral head to either sublux or dislocate from the glenoid fossa. So, we think about the shoulder obviously as a very mobile joint. It can move in all planes of motion. The most mobile joint in the body, right? So with that, unfortunately, with all that mobility, we do lose a little bit of stability, and we're more predisposed to some of this instability. And with the shoulder, we can have either a subluxation or a dislocation. So with a subluxation, some of the sources I was looking at was kind of defining that as you'll get the head moving around in the socket, but it doesn't fully remove itself from the socket, and there isn't a forced putting it back into the socket and relocation with that. Versus dislocation, you have a full, the ball comes out of the socket, the humeral head comes out of the glenoid, and a lot of times with that, we do see some other pathology. So it's definitely a more serious type of instability, and something on our subjective exam we want to make sure that, a lot of times a patient will say, well, my joint, if it was really loose, it kind of popped out. We just want to clarify, was that a subluxation or a dislocation? Because like we'll get into, with a dislocation, a lot of times there's other issues that happen other than just, perhaps a labral tear or something like that. There could be a bony involvement or a rotator cuff involvement. And that's something that we want to know, and, perhaps get that person in for imaging if necessary, especially if it's been multiple times dislocation. But I think, yeah, those are important things to have in mind when you're evaluating someone with, generally instability.
Yeah, good stuff. And I think that's pretty much what I had read too. When folks have a subluxation, generally speaking, that ball may come fully out of the socket, but it's very quick, goes in and out, right? So patients will kind of feel like the shoulder slid out really quickly and it went right back in. Definitions I've seen for dislocation, ball comes completely out, and then you either have to have it reduced by going to the emergency room, sometimes under anesthesia. And anecdotally, I think the longer it's been out, the worse it's an issue, right? More damage potentially happens for this ball staying out for longer and longer. Or you have to do some sort of maneuver yourself to get your shoulder back in, right? So when you watch like the movies and someone's shoulder pops out and they ram their shoulder into the tree 7 times, right, in order to get it back in again, that'd probably be considered a dislocation and not a subluxation, right?
Yeah. That's how I usually treat it in the clinic.
I always think it's funny. You watch one of those movies and someone dislocates their shoulder, and all they have to do is get the shoulder back in, and all of a sudden they're shooting guns again and they're good to go. It's like, come on, dude. Like that thing is going to feel terrible afterwards. To go along with the video today, I have a little gift for you. It's an evidence based cheat sheet for shoulder instability. It's a 4-page PDF that goes over everything you need to know about shoulder instability. We go over prevalence, anatomy, joint arthrokinematics, risk factors, and different types of instability, causes of instability, whether or not your patient should undergo surgery or have conservative care like physical therapy, and finally, rehab implications for all the different types of instability. So if you're looking to get up to speed about shoulder instability in less than 10 minutes, then this PDF is for you. I'll leave a link in the show notes in the description. Go ahead and click on that and then download it and then get back to what you're learning about right now. Yeah.
So just a little bit about like the incidents, how frequently is this happening? So what I was reading, about 1 to 2% of the general population will experience shoulder instability. And we see the highest rates in younger folks, so generally between the ages of 16 and 20. And I think that could be for a few reasons that, we'll get to eventually. But I think these folks tend to have a different type of collagen. There's something I came across is that I think it's like a type 3 collagen. It's a little more stretchy. And as we get older, that kind of changes. So it makes the shoulder a little more stable. And then also, I think these folks are doing a lot more activity, right? So a lot more like physical activity, playing sports, overhead sports, physical contact sports. That may account for some of the instability we see in that population. And then there were a couple interesting studies that I came across, and I think this kind of gives some value to what I was just saying in terms of whether it's a physical sport. Maybe in a younger age you have more higher rates of dislocation. Because in this study looking at the U.S. military, I'm thinking, that's not super, it's physical, but it's not contact. And what we see, and when they looked at this group of 4,000 students in the military, 2.8% incidence of instability in that group. And then they just tried to classify, what percentage of that is having a subluxation and what percentage is having a dislocation. So subluxations are way more common. This study found that to be about 85% of those instability events versus 15 for dislocations. And then when we look at a contact sport, this rugby study I thought was pretty interesting. So they had 378 male high school athletes, and they found the instability incidence to be 15%. So a lot higher than in the military group and a lot higher than in the general population. So I think with these contact sports like football, rugby, hockey, we probably will see a higher incidence if you're working with those populations. And just anecdotally, like at Champion with the active populations we work with, I would say shoulder instability makes up a lot more than 1 to 2% of my caseload. It's, very high. And then I thought, on the point about dislocation versus subluxation, athletes with a previous history of dislocating entering this season where they were following the athletes through, 55% of them had a subsequent dislocation. So, I think that's a big deal. And kind of what you said in the intro, maybe if we have someone come in with a dislocation and we're not, paying attention so much to what the research might be telling us is best for the patient, and something I've definitely been guilty of, trying to just rehab them conservatively. But they may be at higher risk of dislocating again, especially if there was enough tissue damage and we weren't aware of that in the rehab process. So, I thought that was interesting and something to, if you have someone come in with a dislocation who's playing a contact sport, unfortunately, there's a pretty high percentage chance that they could go ahead and have another dislocation, which, more instability, more tissue damage type thing.
Yeah, and that's kind of what I was speaking about previously. If an athlete has a shoulder dislocation and the first person they see is a surgeon, which happens a lot, and most of the studies that we read through, I'll leave a link in the show notes if you guys want to check out the references. They will actually recommend, even for first time dislocations, to get a Bankart repair or some other sort of repair for the shoulder, even after they've had dislocation, haven't trialed physical therapy yet, right? We'll get into this in future shows, and this is part of your decision making. But when a patient comes in, that traumatic anterior instability event, there's a good chance it's going to happen again, especially if you're in a contact sport. So I think as physical therapists, we're always trying to do the conservative thing, but I think what we should probably be doing is what's best for that patient. And they should know. I mean, I had a patient at one point who had two dislocations, was a rugby player, and really did not want to get surgery. And we kind of pushed him that way and rehabbed him. And we got really lucky. He came back and he didn't have another dislocation for the rest of the season. But I think you're playing with fire, right? And as Kevin said, not to steal his thunder, because I think he's going to talk about this a little bit later. If you have more concomitant pathologies, right, and this could be a rotator cuff tear, but the other thing could be is bony damage, particularly at the glenoid. So we talk about the ball and socket joint being unstable, like this golf ball on a tee, and that's true. It's not as congruent as, let's say, the hip, but once you start losing the glenoid, it becomes easier and easier to re-dislocate over the course of time. And the other piece is that if you dislocate your shoulder and tear your labrum, but you don't tear or don't injure any of the bone, you go back, you recur, and then you chunk off a piece of that glenoid, then you might be looking at a different surgery like a Latarjet or something, just because you no longer have that bony congruency. So if you tell folks like, hey, you're fine, let's try conservative first, send them back, you might be putting them in a position where they get hurt again, right?
All right. So now if we're thinking about, we've gone over instability, dislocations, and subluxations. And now another way we can think about this to categorize people is it like a traumatic type thing? Is it a multi-directional type thing where they're loose, from the time they were born growing up, they're more loose than other folks. So a way that they've gone about categorizing this is using some different acronyms. First one is TUBS. So this stands for traumatic unilateral. Oftentimes there's a Bankart lesion. And oftentimes, as Dan just alluded to, they'll opt for surgery. So they call these folks, they're torn loose. So they weren't loose to begin with. They had some type of traumatic accident and they ended up tearing. A lot of times it's accompanied with a Bankart lesion. And unilateral kind of just speaks to, it's traumatic, it's happening on one side, unless you have kind of a freak accident where you injure both shoulders. Generally, with this type of presentation, that traumatic injury for instability, they're going to have anterior instability. And what we see there is usually the mechanism of injury is kind of that horizontal abduction, external rotation, a little bit of extension. So I could picture in sport, like if you're a football player and you're going to stiff arm someone and then someone, kind of hits your arm backwards, your arm kind of like fulcrums to the front and irritates the anterior capsule. With that, some of the different issues we see is a Bankart tear. So that anterior labrum will kind of tear off the glenoid rim. You can have like an anterior capsule injury too to some of those ligaments. A Hill-Sachs lesion. So, we'll get into this, but, if the humeral head comes out anteriorly, kind of on its way back in, the posterior superior part of that humeral head will chip off. And, I've seen some of the articles we were going through for this that if a surgeon sees a certain percentage of bone loss on that humeral head, um, I believe some are over like 20% is what they consider definitely surgery. And then it can be a little gray if it's a lot less than that. It kind of depends on the surgeon and their specific wants and stuff like that. But that's something to consider is how much, if there was bone loss, how much, and it's common to have bone loss with this. And then a little less common with this type of presentation is a posterior instability. So that we're kind of thinking the opposite, maybe horizontal adduction, internal rotation, or flexion force that can tear the posterior capsule. And the posterior capsule is pretty thin, but I guess that we just don't do as many activities in those directions that cause our instability as we do in the other direction. And we can get similar issues with that. So we can get again, a bank heart repair. It would be a reverse bank heart, so kind of on the other side, a posterior capsule tear, or a reverse Hill Sachs. So same type of mechanism where that humeral head's going to dislocate posteriorly, and then on its way back in, the anterior medial part of the humeral head can sustain some bone loss. So again, that's going to be something that if you're unsure about, you probably want to refer for imaging and just get some baseline on how much bone loss these folks had, and let the surgeon and you and the patient come up with a plan for how to best attack that. And sometimes it will be surgical.
Hey, good stuff. Um, I guess just to reiterate, I think generally speaking, if you're trying to figure out what type of instability someone is going to be dealing with, you can ask about that mechanism of injury. So, just like Kevin was saying, if you have anterior instability, which is around 95% of all cases, an external rotation, abduction. So, if someone's running past you and grabs your arm and tears your arm back, that makes sense. Probably having a tear anteriorly. The other one that happens sometimes is someone's arm goes into hyperextension, right? And maybe you fall on your arm in hyperextension. It kind of pops the ball forward in the socket. Those are definitely going to be most common. It's interesting. The body is probably smart, right? I'm assuming. But I would imagine that if 95% of all dislocations are going to be anterior, it makes sense that the anterior inferior capsule is nice and strong, right? Whereas the posterior, not so much. And I think, Kevin, do you have posterior instability or anterior? I don't remember.
It feels like posterior. Yeah.
Yeah,
So for me,
nice.
like that horizontal adduction, if you do like the posterior, posterior like fulcrum to my arm, feels very scary, feels terrible. But it's
Yeah.
interesting because I think about that mechanism, and it's back when I was doing CrossFit more, and I was doing a pull on the rings for like a muscle up. And I wonder if it was like the extreme force for using my posterior deltoid, to pull myself up, that it did, maybe it pulled my humeral head really far back. I definitely didn't have like the kipping technique down I needed on the rings. So it was probably 95% arms and 5% core.
Yeah. Yep. That does kind of speak to the mechanism of injury sometimes, right? So if you're hanging from, let's say, gymnastics rings, for guys who don't know what that is, just basically rings. Like if you watch the Olympics, they're doing gymnastics, they're doing the ring event, kipping, right? So basically you're hanging full body weight, and that's pulling the ball up in the socket, and the body's pulling down. Those traction forces going on. And like you had said, if you forcefully engage, let's say the lats or some other musculature that pulls the ball backwards in the socket, right? And most folks that have posterior instability, they're going to have trouble with arm across body, internal rotation, and end range flexion, because all those things challenge the posterior capsule. So if you're hanging in basically a pull up position and you're gauging a bunch of muscles that pull the ball posteriorly in the socket, when that posterior capsule is already being stretched, may cause some issues. I had a nice little posterior instability event. I've actually had a couple. I think I actually started in high school wrestling, just being on hands and knees, and someone kind of pushed me forward, land on my hand, and the ball kind of went posteriorly in the socket. And I've had, I want to say, 4 or 5 subluxations. And then I would say a little over a year ago, I think I had a true dislocation where it popped out for maybe 5 to 10 seconds. And I just flexed my shoulder, went right back in again. Um, and I've been really lucky with that. But that was an arm across the body mechanism, right? So I essentially have my arm across my body. I do Brazilian Jiu Jitsu, arms across my body. Someone was trying to control me by pulling my arm across my body. I wanted to pull it back out again. And kind of as you said, I think I pulled my own ball out of my socket, which is kind of a really interesting thing to think. But arm all the way across the body, stretching the posterior capsule out quite a bit. I'm aggressively firing the musculature in the back of my shoulder, try to get my arm back. And I just felt my ball just go back in the socket where it shouldn't go. Felt kind of a tearing sensation. Went back in pretty quickly. So I was lucky and I've been able to rehab it. So yeah, that mechanism of injury is going to be really important. In the subjective, you can often tease out the direction just by trying to figure out what was that mechanism, what was the position they were in, to try to theorize what's going on. And obviously, you can lead up with objective tests and try to figure this out.
Totally. Is your shoulder back to like 100%, you feel like?
I feel like it's pretty close. I do
Yeah.
everything that I want to do. There's nothing I think about movement wise that I can't do. I will get a little sore in the back of my shoulder after doing certain things, but it's relatively minor, and it's just gotten better and better. So I think I've been pretty lucky. Um, we may note on some of the rehab stuff and whether or not you decide to go more conservative versus not a little bit later. But so far, I think I'm happy with my decision to
Yeah.
not get
Yeah. We'll talk
surgery.
about that. It'll be interesting. I think unsurprisingly, you did a crap ton of rehab for it. I think you're really good about that. When you have something going on, you practice what you preach. When you're in there, like doing the craziest exercises to stress the posterior capsule and just hammering it for months. And yeah, that's awesome.
Sometimes.
Yeah.
That is a
Right.
big problem, though. We'll talk about some of these stats later, but dislocations are kind of like ankle sprains. People don't take them that seriously. They get back to sport really quickly, and there's a super high recurrence rate. So I'm curious if we did a better job, if things would be better. But just guessing, right?
Yeah, totally. I feel like especially subluxations, some people just think it's like their norm. It's a normal thing, and so that's kind of wild. But
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free Mini Course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning.
We've talked about this a little bit. Just a quick note on the dislocation versus the subluxation. Um, Again, when you're doing this objective, you do want to try to tease this out because there's generally a lot more tissue damage with a shoulder dislocation. And then these were just some interesting statistics. So Owens was a kind of a big name. I can't remember his first name, but for going over some of the instability research, I think he's a medical doctor, not a PT, but he had a lot of good articles out there. So This one was looking, he was citing another article where they reviewed initial dislocations of 63 young athletes at the U.S. Military Academy, and they found in that group that 97% had a Bankart tear and 90% had a Hill Sachs. So a first-time dislocation, those very high rates of, some pretty significant pathology. So it's not like it just pops out and now they're loose. There's some anatomical disruption there. And then in the same article, he also cites another paper where, we were talking about age a little bit earlier and how that influences instability. So he reported on 227 patients with a primary shoulder dislocation. So first time in the anterior direction. And if you're over the age of 30, these folks only had a recurrence rate. And I can't remember the time span in between, how long they were following these folks for. I'd have to look at the study. But if you're over the age of 30, only 27% had another recurrence of a dislocation. But if you're 23 or younger, so one of these younger folks, you had a 72% recurrence rate. So those statistics are pretty wild. It's like if you're 35 years old and you have a dislocation, I mean, there could be a significant amount of trauma. You'd want to get that, repaired probably, depending on the amount of anatomical damage. But, if it's kind of borderline, we might have a better chance rehabbing those folks just looking at this data versus if you're younger. And one of the statistics I came across, I think we'll talk about it in a future episode, but one study was citing if you were under the age of 10 years old and you have a dislocation, your future risk of dislocating was 100%. So, if you're really young, it's just like, it's going to happen again. So it's kind of crazy. And then when we don't manage this the right way and there is, recurrence over time of instability, it does seem to correlate to higher rates of osteoarthritis. And, this could be something that matters down the road. You might be young and think, whatever, I can deal with it doing this. But if you do educate those folks that they might need we might have higher rates of arthritis, and that could potentially lead to something like a shoulder replacement. That's not something that you want. I think shoulder replacements are still, pretty gnarly. I'd rather have like a hip or knee. Shoulder's kind of scary to me in terms of getting back all your function. So you don't want to scare the folks, but you do kind of want to educate them that, for your long-term shoulder health, perhaps it's better if you're only, 21 years old and you have a pretty significant dislocation to consult with a surgeon. So I thought these were some interesting statistics.
Yeah, I thought they were really interesting too. Of note, and you had kind of said this, I think that I don't know, two things. One, in the social media landscape, a lot of folks kind of say, all right, everyone has a tear. You have a tear, I have a tear. My labrum's torn, your labrum's torn. Why does it matter? In the case of anterior instability, obviously this matters quite a bit, right? So I think this is one of those cases where if you have a big old tear, big old Bankart lesion, good chance that is going to be problematic and is potentially a great reason to get surgery, right? As we're chatting about. I think the other piece is that from a special test perspective, we're always looking for something that kind of has high sensitivity specificity. If you have an athlete and you're pretty sure they dislocated their shoulder, you can be almost certain they also have a Bankart lesion as well, right? So it's one of those instances where it's pretty cut and dry. If someone has a major instability event, dislocation, they haven't seen a doctor yet, I'm going to be very cautious with the way I approach that shoulder. I don't know that I need to do a ton of special tests to provoke that joint. Last thing you want to do is have it dislocate again. You kind of know what's going on. So I don't know. Just be cautious when you approach these patients because they're going to be very scared. And then we kind of know what's going on just based on that subjective information. We probably don't have to push them too much objectively, right? The other one I thought was really interesting is this recurrence rate. And I tell this joke to my patients all the time. If they ever have like a dislocation or anything like that and they're older, it's like, this is like the only time where being older is better, right?
Yeah.
And Kevin also talked about this a little bit. We're not exactly sure why these recurrence rates are lower, but it probably has something to do with the type of collagen you lay down as you get older. So sometime after the age of, let's say, 30 or so, it even seems to be sooner than that, right? So even our 20s, it seems to be better than our teens, right? And then 30s, 40s, 50s, it all seems to improve with age, which is hilarious. We tend to be stiffer. We put more collagen down that's stiffer after we have an injury, which is nice. And then you don't see a lot of like 50-year-olds trying to get back to rugby, right? So I think the reason why you see these recurrence rates a lot lower is simply because what folks are trying to get back to is a lot less. And even for someone like myself, right? So I still do, something that has a decent amount of, let's say, contact, falling on that shoulder, with jiu-jitsu is kind of like a wrestling sport. I still take it way easier than I would have if I was 17 years old. If I was 17 years old, I wouldn't think about it whatsoever. I put so much thought into what I do now to make sure I don't hurt myself. So I think age is just one of those things that educates us, makes us a little bit wiser and smarter with the way we train. So I think because of that, we're maybe a little less likely to have a recurrence as well.
Yeah, awesome. So just kind of picking up. So we went over kind of those torn loose folks. Another presentation you'll see, or you'll see in the research, the way they categorize it is ambry. So this is someone who is born loose, more of your multi-directional instability type person. So that's atraumatic. There's no trauma, not a clear mechanism of injury. They tend to have multi-directional instability. So then you are thinking, this could be a genetic type thing. They're loose in all directions when you do some joint play. Bilateral, which again makes sense. This is probably just their genetics and their anatomy a little bit. If there has been no significant dislocation or crazy types of subluxations, this is something we could probably go for conservative rehab. At least we definitely want to start there, and then we can consider if this isn't working. A lot of times surgeons will do a procedure where they do like a capsular shift to tighten up the capsule a little bit. So that's something that we'll get into in terms of rehab and how we approach that. But again, an unstable shoulder, but a different presentation from that traumatic type instability. And then another one that I feel like we see a lot at Champion, a lot with overhead athletes, is there isn't necessarily a type of trauma. It's not like they had a dislocation event or anything like that. They might not have been born loose, but maybe we see this with baseball players and gymnasts. And this is called AIOS, or acquired instability overuse syndrome. So perhaps when you have somebody who often is, we talked about that anterior capsule being pretty robust, the anterior inferior capsule. A lot of times in baseball players, we see when they're always back in external rotation throwing, sometimes if they've adopted a pretty aggressive, weighted ball program, or they're doing a lot of stretching on their own into external rotation, we can see some instability that they've acquired over time that they don't have on the other side. So I think these folks, we might also try to rehab them conservatively, unless they start getting some, more subluxation events or a dislocation event. They might be more prone to that after years and years of acquired instability. But another presentation you'll see is that AIOS type presentation.
Yeah, for sure. A couple things to think about. So generally with the born loose folks, these are the folks that tend to do a little better with PT. And we'll kind of talk about this a little bit later. But if someone has that, frank instability dislocation, you're thinking, all right, we need some imaging, and then we could consider doing some conservative physical therapy. We have to be really careful with that. The folks that have the multi-direction instability, they tend to do quite well with physical therapy. And they also may go on to get surgery, but I mean, it's not flipped, so it's not like you're thinking about doing surgery from the get-go. It's kind of more, let's treat this conservatively. And after a while, if things aren't going our way, we can think more about surgery. The other piece is for folks that have multi-direction instability. You will probably notice that they have a lot of range of motion, right? If you do some capsular testing, drawer testing, glides, just to get a feel of the capsule, you usually have a lot of motion, right? The other thing these folks have is called capsular redundancy. They just have a lot of capsule. So when you watch them bring their arms overhead, the shoulder blade doesn't move very much. Because if you think about it, 2/3 of the motion overhead is supposed to come from the glenohumeral joint, 1/3 from the scapula. These folks have so much motion at the shoulder joint, the scapula doesn't always go along for the ride. So you'll notice that when they do activities with their arms, particularly abduction or flexion. And the other piece is from a rehab perspective, and there's some papers on this. You can attempt to try to have the patient use their shoulder blade a little bit more. So we're not getting so much motion from the shoulder joint. We're getting a little bit more help from the scapula. Tends to be helpful for these folks. So a couple things you can do from a rehab perspective. The other piece I will say is that we talk about this instability being a negative thing. In some ways, it may be a positive adaptation, which is funny because I don't know the stats. I'm not a huge baseball guy, but obviously I'm in a baseball facility. But for every degree of external rotation you get, you can add more velocity on your throw. So a lot of folks are trying to get more layback, right? And that may be beneficial to throw faster. But then what we'll see is that their total range of motion ends up getting bigger and they're just stretching that capsule most likely. So if folks are getting more and more flexible over the course of time, we just have to be careful with that because they might be overdoing it, right?
Yeah, it feels like, especially if you see the kids who are born loose and then they go ahead and try to add a bunch of external rotation, that's when they really see it seems like they really get into trouble. And like you said, their total arc changes, and you might see 15 or 20 degrees more total motion on that side that they've been working on motion wise. And it seems to come with a host of problems for them. So like you said, it seems like the best pitchers we see have a lot of motion. They just are perhaps born loose, or they've had that like acquired instability over time that made them a really good thrower. But it does come with risk.
Okay, so now you have the basics on shoulder instability. Next thing to discuss is going to be surgery or physical therapy. What's the best thing for your patient? Here we go. Surgery versus conservative care for shoulder instability.
Ooh, yep. Today we have a paper um, that we're going to go over that kind of gives us some insight into whether we should consider surgery or conservative care. And then the title of this article from Brett Owens and colleagues in the Journal of Orthopedic Surgery was the management of mid-season traumatic anterior shoulder instability athletes. So in season, these athletes are having some anterior instability, trying to figure out how to best manage these folks. And I thought this was a very insightful paper and definitely took away some good pearls from it.
Yeah, I agree with you. This is important for physical therapists, especially sports physical therapists. If you're seeing athletes that are coming in after they've had some sort of instability event, subluxation or dislocation, your decision making is key. Because if you make the wrong decision, you could be setting folks up. And I hate to be a fearmonger for long term issues, recurrent instability, arthritis, all sorts of bad stuff. So I think in the social media world, we're always very hopeful. We want to try to rehab everyone that comes through the door, avoid surgery at all costs. This is a situation that's maybe different than most, I'd say. So I think it's a very important discussion. I don't know, it's a little sad. It's one of those things where I think physical therapy isn't as powerful as we'd like it to be. But obviously, we care for patients. We want to do what's best for them. It's not all about healing everyone with our, exercise, hands, whatever else it is, right?
Awesome. Yeah. So, just regarding a little bit of information that was interesting from the abstract. Um, so, the reason why they did this is they were saying that regarding optimal treatment of an athlete with an in season shoulder dislocation, there's very limited data to guide treatment. So, we looked to the research for some answers, and there wasn't a ton, and they decided to come out with this paper. So, this was in 2012. But I think it's a pretty powerful paper today.
Yeah,
So,
I added some other references that are newer and it's still the same. It hasn't changed. Yeah.
awesome. Yeah. Yeah. Same stuff. So, um, what they find is rehab may facilitate a return to sport within 3 weeks, but like we've talked about in the previous episode, there's a high risk of recurrence. So, Buss and colleagues found 87% of athletes return to play in an average of 10 days, but there's a significant recurrence rate of 1.4 per athlete season. So try to get these folks back, but like you were saying previously, we might be doing them a disservice. We might not have all the tools at our disposal to prevent the recurrence.
Yeah, for
And we'll
sure.
talk about this, but bracing may reduce recurrence, but it comes with a con of perhaps restricting their range of motion for sport. So if you picture that baseball pitcher, they have some instability. You put them in a brace for a few weeks to prevent recurrence, but now they could be very tight. And if we're mid-season, that could mean more time that they miss as they try to get their motion back. Um, but then, on the other hand, surgery, it reduces the risk of recurrence, but then the athlete misses significant time. And, this is the tough thing that you were talking about. I kind of hate telling people no and telling people that they can't do something or being the bearer of bad news. I try to be like as optimistic as possible with patients all the time. I never want to be like nocibic and make them feel like crap. But this is the hardest thing for me is if I really do think we need to miss some significant time and surgery is going to be the play. Um, Breaking that news to someone is the worst thing ever. They get all upset. It could be their senior season of high school. They're not going to play in college, and you just feel terrible. But we'll get into kind of what Owens does in this article is help us with some criteria based decision making.
Yeah, for sure. I added that. What's funny is Kevin actually made slides for this presentation. If you're listening to this on the podcast version and you can't see it, there's a video. There actually is a video to this. If you go onto YouTube, check it out. But we have slides we're going off of, and Kevin did his due diligence and made some incredible slides. And then last minute, I went in there and changed a bunch of stuff. So just threw that curveball, and Kevin's reading that stat. But anyway, that stat by Bus basically showing that a large majority of folks are going to have 1.4 more dislocations over the course of their season, which is pretty wild. And it gets worse if you are more of a contact sport. So let's say you're playing rugby or football and you're halfway through your season, you have a dislocation, you're probably going to have a couple more when you return back, right? We already discussed this in the prior podcast, so I'll be short. If you have more recurrences, it's more chances for concomitant injury. So let's say the rotator cuff, the brachial plexus gets dinged up, and you start losing more bone. So on the humeral side as well as the glenoid side. And that's going to potentially require more challenging surgeries, right? We don't necessarily want to go down that route. What I thought was interesting too, and I will say that I've had the same kind of experience myself, is that return to play is very quick, which is super misleading, right? If you think about a tendinopathy is a little bit more safe to push through pain. When someone has a dislocation, it just kind of feels better quickly, right? Which is super misleading. And it just reminds me of ankle sprains. So ankle sprain stats are very, very similar, right? People have return to play within like 1.2 days. It's crazy. People get back so fast. And oftentimes they're still playing through pain. But the recurrence rates are incredible. They're so huge, right? And what is interesting to me too is that for these folks, if you do a very thorough job with the rehab, the recurrence rates are actually quite a bit lower. So I'm not saying that if you do a great job with your rehab, then your athlete will be fine. But I would be curious if people gave it a longer period of time to rehab conservatively and then try to return, if that would change some of these recurrence rates, redislocation rates. I don't really know, but I just thought that was really interesting.
All right. So we have this table here from the article, and what it's showing is indications for non-surgical management of traumatic anterior shoulder instability. So some injury characteristics that we'll see are an initial shoulder dislocation, um, an osseous defect of the glenoid less than 25%, so less than 25% bone loss in the glenoid rim. Same thing with the humerus. So a Hill-Sachs osteo defect of the humeral head less than 25%, and absence of fracture or soft tissue injury that requires surgery. So in this type of scenario, they're saying this is something that perhaps we could try to manage conservatively. I think what is of note here, though, is if you're a PT with direct access, you don't know these things unless they go ahead and consult with a shoulder doc, right? We can't tell how much bone loss they had. We can't tell if there was other soft tissue injuries, or we might be able to tell if there's a brachial plexus type injury, but we have to probably get these folks in anyway to get some baseline imaging. And then I think the time of year matters for this person in terms of their sport. And if they have 3 weeks left of their last season, perhaps they finish it out conservatively. So we always take those things into considerations. So the characteristics they talk about for this sport specific and the player characteristics where we will try to manage conservatively is that they're in season and the athlete really wants to return to sport. I think that's a big one because we can have all the data to support that the person should have surgery, but it always comes down to what the patient wants. And I think it's just our job, as long as we're giving them proper education. I try to tell my patients that in these type of scenarios, it's a risk reward type equation. So I think we're a little bit on the risky side, but as long as they understand what's at play, I'll let them make the decision. If it's a non-overhead or a non-throwing athlete, and they also play a non-contact sport, so this might be something like soccer type thing. Only few sports I think fit in that category. They could be someone that could return non-operatively, and also if they can complete sport-specific drills without instability. So I think this is where we would be in rehab, and we would be testing people and seeing as sport specific as possible at that end stage of rehab. How do they feel? What's their confidence level? Are they having any instability? If they're kind of checking those boxes, and then just some other things I put on the side here, um, if their range of motion is pretty symmetrical, we're doing some dynamometer strength testing in provocative positions, and it's pretty symmetrical. They don't have any apprehension. Maybe these folks, after a course of a couple weeks, and they're hitting these markers, these criteria for progression, we can try to return to sport and kind of take it from there and see what happens. But I think if we're unsure, we have to refer for imaging of how much potential bone loss. And if they're not hitting any sport specific criteria in rehab, they're not hitting good strength and range of motion, then I think we're putting them at risk, and we're leaving a lot of information on the table.
That was some really good stuff there, Kevin. I like that. So, I think one of the big takeaways if you have a patient that has a dislocation, or you think they had a dislocation, probably wise just to send back to the doctor, right? We need some imaging to figure out how bad it is. You can use some special tests to try to figure out maybe how bad it is. If someone has gross weakness, maybe there is some rotator cuff stuff going on in there, right? So if we tore part of the rotator cuff tendon, I think it's greater than 50 or 75%, probably want to have surgery after that. For having gross instability. So anytime I try to get them to any degree of external rotation, they feel very unstable. That'd be another reason to send. But as Kevin said, we need more information. So this is one of those situations where I would send back to the doc right away. I wouldn't wait on that. Better safe than sorry. The doc may send them right back to you, right? But that's okay. Then you can start with your conservative approach. But I do think it's smart to send to the doctor. And I think the other important point you brought up is that ultimately the decision really is up to the patient. I've had some patients. I think I was mentioning the other day about one patient that had multiple dislocations, rugby player, was going to start their season, didn't want to get surgery, didn't want to get any imaging, right? And I just really told them how important I thought it was. They decided they didn't want to do it. And they actually had a great season. It was very, I would say, lucky. And this individual, it's wild. He must have been a very loose individual for this to happen. But after several dislocations anteriorly, he got MRIs with arthrogram, never had any sort of labral tear. And that doesn't make any sense to me. Like, how can you dislocate several times and not have that happen? But yeah, educate the patient about the risk of returning back mid-season. We just told that stat. You're likely to have this recur 1.4 times, right? And if you're younger, if you're going back to contact sport, even worse, potentially, maybe a little bit less if it's going to be a non-contact sport, but it's still quite high. And as long as the patient has the information, they can make their own decision, right? Like Kevin said, let's say it's a football player. They only have one more game left in the season. They're not going to be playing in college. All they want to do is return back to play for this one game. It's incredibly important for them. They understand the risk of it. Then I can understand that, right? I mean, my thought is like, well, you need that shoulder for the rest of your life. You probably still want to potentially go and get surgery, but that's me, right? That's not the patient. If the patient feels it's important enough to them, then they can kind of go for it. So as long as you educate them and they know what's up, they can make their own decisions.
All right. And then kind of to contrast that, here is a chart from the study that's talking about indications for early surgery. So what folks are we just going to say we should do surgery on? Kind of the opposite of what we were just talking about. So if they have a glenoid bone loss of over 25%, that, like you mentioned, the greater than 50% rotator cuff tear, an off-track Hill-Sachs lesion. So, I believe this is where they have enough bone loss in the humerus that when they start to move their arm in certain degrees of motion, it's kind of off track and we're getting some abutment of the bone loss area with the glenoid, and the humerus can kind of pop out a little bit. An irreducible dislocation. So, I mean, yeah, they can't. We can't reload. We can't relocate it. We can't reduce the dislocation. They're going to need surgery. Um, if there were folks that we thought we could rehab conservatively and they're failing, meaning they either have another dislocation event or they just continue to feel unstable, they can't return to sport, probably want to consider surgery. They can't tolerate restrictions early on. So they dislocate. We want to put them in a brace, perhaps, or a sling, and they're just not adherent to that. They might need surgery. And then, like I said, they can't do sport specific drills without pain or apprehension. So, uh, Owens and colleagues are saying these are absolute indications for surgery. We should be considering surgery in those scenarios. And then we should really be considering surgery, a relative indication list of they've had more than one dislocation in the same season, because we probably risk more significant concomitant injuries. If they're a contact or collision athlete, like a rugby or football player, they're probably, their risk is higher. So they probably want to do surgery. Um, the season's over and we have some time off and we can start to think about how to be optimized for the upcoming season next year. Probably want to consider surgery in that case. If they're young, we talked about the different types of collagen, and there's a chance that these folks are going to continue to be unstable. We might consider surgery for those younger folks. Again, which is so weird because, like you said, in every other case, it's like it seems to be an advantage to be young. We bounce back faster, but I guess instability, it's different. We have to think about it a little differently.
Yeah, for sure. It's funny because I switched up that chart on you. You had the Owens one in there, and I threw the bus one in there, um,
It's
just
like the same
because
stuff, I think. Yeah.
it was a little clear. It was very similar. Yeah. So the other thing I thought was a little bit interesting is that they have this relative contraindication list, right? And all those things would occur with a dislocation, but the authors also advocated for surgery after a primary first time anterior dislocation. So despite that chart saying relative contraindications, the authors concluded that they should still get surgery. So um, I would say that you want to proceed with caution anytime someone has any sort of dislocation anteriorly. But obviously, those are some of the things you can think about with your decision making to educate the patient about and decide whether or not they need to go back to the doctor if you're the first point of contact.
Awesome. And here's a kind of, it's a little blurry, but it was hard to fit all on the slide. It's a algorithm from the Owens paper. I'm not going to go through every specific thing, but I think it will be helpful for folks to look at and maybe use in their clinical decision making. So, it kind of takes you through, you have an in-season instability event. You probably want to refer for imaging, and they're just, if it's geared towards medical doctors, they're recommending a certain type of MRI, um, certain type of image from a certain angle. And then they're going through and just saying if there's a certain amount of bone loss, let's consider surgery. If there's a certain amount of soft tissue pathology, let's consider surgery. And then, the algorithm kind of brings you to surgery or rehab conservatively. And it's based on the things we were just talking about. So I think if you're watching the YouTube version, it's helpful to look at that. Or if you want to look up the study yourself, I think it's a nice flow chart to have maybe with you in the clinic, just to keep that on the top of your mind about, is this someone I should be referring or should we be trying conservative, at least for now?
Yeah, I thought it was good too. And even just looking through it, basically get some imaging. Is there greater than 25% bone loss? If yes, get surgery. If not, what's a soft tissue look like? If it's okay, go ahead and try physical therapy. If you can't get back, it just keeps on, dislocating, surgery. Where did this happen? If it's at the beginning of the season, maybe consider physical therapy because you have more time to do a good job. Whereas if the end of the season, straight to surgery. And the last piece is that when you do your physical therapy, can you actually return to sport specific drills, which I think this is huge. If you have a patient that's just not getting back to the specific positions they need to get into for the sport, like there's no way it's going to work out well when someone slams into their arm full speed, right? Then you would consider surgery. But if they're getting back to sport specific activities, then maybe they're okay to return back to sport. So Okay, so I thought this was a really cool study that helps highlight some of the points we're talking about. I'm just going to read the title because it's pretty self explanatory. Non operative management of anterior shoulder instability can result in high rates of recurrent instability and pain at long term follow up. I'm just going to read the conclusion here because once you hear it, it all makes sense. A long term follow up of 17 years, which is awesome because it wasn't like after one season or at the 1 or 2 year mark. It's 17 years later. So you can see what's going on with that shoulder after you've had a dislocation. There's a high rate of poor outcomes observed following non operative management of anterior shoulder instability. Overall, 37.5% of patients experienced recurrent shoulder instability, 58.4% had recurrent shoulder pain, and 12.2% had symptomatic osteoarthritis development. Risk factors associated with adverse clinical outcomes included increased pain at initial visit, which basically, if you have an extremely painful person, that's going to dictate how slow you go with rehab, but potentially how bad it's going to be long term. Recurrent instability prior to presentation, a seizure disorder, which obviously you can have dislocations with that, and smoking, which smoking seems to be like the worst thing you can do for your body.
Yeah. Wow, those
Yeah.
stats are crazy.
Yeah. But anyway, this stat makes me feel bad about deciding to go conservatively first, right? Just because if you make the wrong decision, there's a chance you're setting some up for long term pain 17 years later, more osteoarthritis, so on and so forth, right? And for some folks, maybe conservative care is the right. I feel like I'm just advocating for surgery, right? And that's not really the case. I just want to do what's best for the patient, really. In some cases, you might be able to get away with conservative care, especially if it's an older individual that doesn't want to get back to a contact sport. But just keep in mind, this is a major decision, right? And you want to make sure that you're setting your patient up for the best long-term solution. And sometimes that may be with surgery. All right, so now I have a good idea of whether or not your patient's going to need surgery first or physical therapy. Next, we need to understand some principles of rehabilitation. And now we're going to learn about that. In today's episode, we're going over principles of non-op rehabilitation for glenohumeral instability.
Oh, yes. Today is a paper by Kevin Wilk and his colleagues, which happen to be our bosses at Champion PT, on some of the non-op rehab for the traumatic and atraumatic glenohumeral instability. So Wilk, Macrina, and Reinhold.
Nice.
What a trio.
Leonardo, McCreener,
Yep.
Michael Reinhold.
Yes.
Yeah, we
What
know
a
those
crew.
guys.
Yep.
Yeah. One of the
Big
things I will
guys.
say about this article is that, both Kevin and I did look through a lot of the literature over the past couple of weeks when we're trying to decide what are the best articles that we could use to talk about basic rehab principles. And what's kind of interesting to me is that there really wasn't a whole lot that changed since this article in 2006. And I think the article from 2006 did a really good job of going through a lot of really important principles other papers didn't. So despite this being an old study, it's still a really good one. And I think it's going to give you a lot of the critical reasoning skills that you need when you have a patient with shoulder instability that presents. So I'm pumped to bring it to you.
Yeah, so kind of the way they structure this paper is they divide it into 7 keys for the clinician to consider to guide the rehab process. So, just very quick: onset of pathology, degree of instability, the frequency of dislocations, the direction of the instability, if there's any concomitant pathologies, and then working on neuromuscular control and getting back to before the condition activity level.
And I think there's a lot we just threw at you, but when you're thinking through where you should start with your exercise, which exercise to choose, and how you progress, these are all the factors to consider. And there are also some of the factors you consider if you think this person ends up needing something like surgery. So you can use them to help guide your treatment.
Totally. And I think if you have a evaluation coming up with a patient with shoulder instability, you could just have these in front of you in your subjective exam and try to figure all these things out. And I think you'll end up in a pretty good spot. So the first one they talk about is the onset of pathology. We talked about this in previous episodes, but trying to figure out, is this an acute or is this chronic shoulder instability? Is this someone who is born loose or someone who was torn loose? So was there trauma, or is this perhaps a genetic instability type thing? And again, that's going to matter because if this is someone who had a dislocation, we know they're at a lot higher risk of recurrence. If they haven't had one and they're just generally unstable, these are folks that do really well with conservative care and with physical therapy. So these born loose folks, maybe these multi-directional instability folks, we can be pretty aggressive early on with our treatment. And that's something that I know Dan's going to hammer on a future podcast. So stay tuned for that. As well, we want to look at the second big thing here is the degree of instability. So again, are they subluxing? Do they just feel loose? Have they had a dislocation? All the things we've talked about. If they have, we might want to get them in for imaging and figure out if there's any concomitant pathologies. How significant is the Bankart tear? How significant is perhaps if there is a Hill Sachs? How significant is that? So we don't want to guess. We want to get them in and figure out what the degree of instability is.
Not to give too much away because we're talking about this more in future podcasts, but I think the other one is that how unstable do they feel, right? So you need some imaging to see how bad the damage is. The other piece is that can they get to end range external rotation? Are they able to flex fully overhead? If it was posterior, can they go arm across the body? Because that's going to really dictate a lot of what your physical therapy early on is going to look like. It's also going to dictate what you need to get back to eventually, right?
Awesome. So key number 3 is the frequency of dislocations. So, same themes here. Is it a first time versus a recurrent dislocation? Um, Either one, it doesn't mean if it's first time that we're automatically going to handle it conservatively. We might need to go ahead and get imaging and figure out this baseline level of tissue damage. But let's assume that we're going to do a little bit of conservative rehab. First time, we consider a protection phase. So, there were some studies looking at slings and perhaps putting someone in a mobilization sling, and like in external rotation seems to be a little more protective. And that will be something that you could work with a doc, with a surgeon. They might have a specific protocol they like for a sling to prevent that recurrence. Um, I think important too is that you're perhaps in rehab. We'll get into this, but doing some early controlled range of motion. So, they had instability. We're not cranking on motion, but we're trying to desensitize the area, get them confident with the arm moving, and then education with the patient. So, if this was a first time dislocation, we have to educate them. If this is a younger kid who does a contact sport or an overhead sport, the chances of this happening again is relatively high, as we've talked about many times. So they have to be aware of that. They have to know that if they're not feeling 100%, the risk is pretty significant. Something else could happen. If they're of older age, there's some education there that that you might have a better chance of doing this conservatively. So just talking to them about all the things that we've covered. And, again, with the age, right? Average as high as 67% of patients, 21 to 30 will have recurrence, and as low as 20% in patients over 30. So something to consider in that education. Um, and then if it is recurrent, we want to assess the irritability and determine maybe what phase of healing they're in. So did they just have the dislocation yesterday and they're in a very spasm type state, a lot of muscle guarding, a lot of fear. They don't want you to touch their arm. We have to obviously treat those folks differently than someone who, maybe was, subluxing in the gym last week. They otherwise feel fine. They haven't had a dislocation event in a while. We can go ahead and kind of get into it in our assessment with them.
Yeah, I agree 100%. I actually don't really have much to add there. What I will say is, we said this in an earlier podcast, is that the more recurrences you have, the worse it tends to be. You might have more osteoarthritis at the end of the day, too. So that's one thing to think about as well. If this person keeps on having recurrences, maybe it's time to think about surgery over trying to continue treating conservatively.
All right. Key number 4 is figuring out what the direction of instability was. Um, the patient usually, you're not going to just say do you have anterior instability? You're going to ask what the mechanism was, and they're going to go ahead and describe kind of what happened as they had this instability event. And, a lot of times they will describe that like their kind of arm was out, and if, a football contact, rugby player, and someone ran into it, or some similar pathology with their arm out to the side and they're getting that kind of force of the humerus translating anteriorly, then we can suspect there's damage there and can confirm that on the table. A lot of times we'll see that classic like apprehension test. You get them on their back, you bring them into external rotation, maybe up at 90 degrees, and they're a little bit fearful of having some instability. So something to consider. And then again, just if we want to get these folks in for imaging because they might have a Bankart repair, they might have a haggle, so a humeral anterior glenoid ligament damage. So something to consider there, or the anterior inferior capsule damage. And then we could see with this a Hill-Sachs or a bony Bankart. So we want to make sure we rule those things out and figure out kind of what the direction of instability is telling us.
Yeah, for sure. And I think we talked about this before too. But if you dislocate anteriorly, you probably do have some sort of tearing of the labrum capsule, right? It could be either a Bankart tear or it could be a haggle. So haggle is a humeral side, Bankart is glenoid side, inferior glenohumeral ligament, right? And then the big thing we want to be on the lookout for from an imaging perspective is going to be how much glenoid bone loss is there. So if there's a lot of it, then they probably want to go for surgery first, right? And it maybe even dictates a type of surgery. So if you have a lot of bone loss, and if you live in France, right, because it's a very regionally dependent thing, you might want to consider something like a ladder J, which provides a little bit more bony support over a Bankart repair, which might not be as good. But we're not surgeons, right? But it is one of the things that I think a surgeon has to think about. Like, what is that first surgery they try to use?
Yeah, just a quick interesting side note. For those listeners who are members of the APTA in the sports section, IJSPT does a monthly journal club, and they actually had a really good one last October with a doc out in Colorado. I think his name was Dr. McCarty, who works with, I think, the Colorado Avalanche, and he's a shoulder doc. And he was actually telling that story, Dan, about how the ladder J procedure was kind of pioneered in France, and they would just go ahead and they would do a ladder J on everyone who had a dislocation, regardless of how much damage there was to the glenoid. They just did it to prevent further recurrence. It seemed to work pretty well, and it kind of seems like you saying now. We'll maybe talk about this eventually, but a remplissage procedure is something that they can use the rotator cuff to kind of stabilize the chip that you get in the humeral head. And that's something that now they're kind of just doing on everybody too. They're just seeing that if you have loss of the humeral head, it's helpful. So if you are a member of the sports section, I think that episode was really good. It was worth listening to. That doc had a lot of good insights and kind of made it simple to understand.
Yeah.
And he was also a fan of first time dislocations almost always doing surgery, which I thought was interesting to hear from a doc's perspective. But anyway, just a little bit more about the direction of instability. Aside from obviously anterior, we can have posterior instability, and paying attention in the subjective exam to that mechanism. The patient might describe falling down on their arm, kind of cross body, landing on their elbow, getting that axial force going posteriorly, and they might have a little dislocation event in the back. And then we just want to maybe confirm that with some special tests. They won't like cross body type stuff. They won't want you to push down on their humerus, kind of in that posterior direction. They might feel unstable there. And with that, we'll see some common pathologies like a posterior labral tear, posterior capsule tear, reverse Hill-Sachs, or perhaps a reverse bony Bankart. So just making sure we're getting that looked at. And then with multi-directional, they feel kind of loose in every direction. They're not usually going to report any type of traumatic mechanism of injury. So something else to just pick up on when you're going through your subjective examination. One test that the research seems to show is kind of helpful for this is just looking at that sulcus sign. I can't remember off the top of my head how much translation you're looking for, but you'll just kind of inferiorly move their humerus when they're in sitting, and up at the joint there, you'll see a fair amount of inferior translation, kind of just showing you some instability there. Maybe like a Beighton type thing would be helpful too, just to see gross instability. Maybe their specific genetics give them that.
Yeah, for sure. These are the folks, again, that tend to do well with physical therapy. Another little diagnostic tip is that they tend to have capsular redundancy. So if you're doing the sulcus sign, what you're doing is taking up all the slack in the joint. You're just pulling all those ligaments and the capsule taut. And basically, you have to pull a lot for it to become taut. So when these folks go into abduction, they tend not to move very much from their shoulder blade just because they have so much motion from the shoulder joint. They have that capsular redundancy that they don't need to move from the shoulder blade. And then from a rehab perspective, sometimes we're actually trying to get them to move from the shoulder blade so that we can decrease some of the stress on the shoulder joint.
Yep, and then something else we've talked a lot about because it's so important is that the fifth key they highlight here in this paper is trying to determine if there's concomitant pathologies. So uh, I'm not sure if this would really be considered concomitant because the bank heart is like it's just happening with the initial injury so often. Um, but you want to watch out for obviously bank heart, a Hill Sachs, or a reverse of the two. A brachial plexus injury. This is something that can be really terrible for the patient. I think I'm working with Lenny, co-treating someone right now who had a pretty significant, massive rotator cuff tear, shoulder dislocation, some damage to the brachial plexus, and it's like wild rehab. It's like you look at him and you're like, is his cuff retorn? But it's just like the nerves. It's crazy to see it. They take so long to kind of regenerate, but that's something you'll want to look out for. And then maybe they have a slap tear, maybe they have a rotator cuff tear, or did they have a fracture of their humerus? So these are all important things to consider. I think, like Dan talked about in a previous episode, you want to just be cautious. If they came in, you're the first provider they've seen, just be like really careful until they get imaging because you don't know how significant the damage is there. And it's something that we have to find out to come up with a good rehab plan.
You mentioned one thing that I thought was pretty important as well. So brachial plexus can be involved with a shoulder dislocation, particularly anteriorly. So we think about where the brachial plexus lies. It's right in the front of the shoulder. The ball comes forward in the socket, or the arm is stretched too far. You can have a stretch injury, or you can have some injury of the ball pushing up against the plexus. We will tend to see some of this sometimes when folks have acquired instability. At Champion, we work with a lot of baseball players. They're constantly in end range layback. We know they acquire some instability in the front of their shoulder just from stretching that ligament over and over and over and over again. Think about what lies in the front of your humerus. One of those structures is the brachial plexus. So sometimes we'll see folks that have anterior instability also have some signs of plexopathy or some thoracic outlet syndrome. So for those folks, stabilizing that shoulder joint may help them a little bit with their neural symptoms.
So the sixth key that they talk about in this paper is assessing for neuromuscular control. And I think this is specifically impaired in these folks at end ranges of motion. So neuromuscular control, the definition they use is a efferent or motor output in reaction to an afferent or sensory input. And then, some ways that we'll test this, we'll do a little bit of like joint positioning. So sometimes I'll put their arm up at a certain degree of motion, whether it's a little bit of flexion or a little bit in the scapular plane, and try to have them go ahead and put their arm in that same spot that I had just had it. How accurate can they do that with their eyes closed? Because then we're taking the visual system out and focusing a little more on proprioception. We can do a little bit of like rhythmic stabilization testing. Again, I think is best done maybe with eyes closed so they can kind of figure out that they're relying on their proprioceptive system and trying to see if they can control that input with good motor output. And again, because your ligaments in the joint capsule, they have a lot of joint position, sensory tissue in there. That's something that's going to be impaired. And I think, we've mentioned the ankle a few times, but I think it makes sense to think about the shoulder when we think about recurrent ankle sprains. Those folks tend to have pretty poor static stability, pretty poor neuromuscular control, and has to be a big part of the rehab program to prevent re-spraining your ankle. I think same thing is the key that they're pointing out here is that this has to be a huge part of our shoulder rehab program. And that's something I've learned a lot from working at Champion, just watching how Mike and Lenny treat these things. It's a ton of rhythmic stabilization type stuff, really just to focus on that one aspect that gives you a little more and might be required a little more than just pure strengthening.
What I will say is, I wasn't. I don't want to say I'm not a believer because I always liked the rhythmic stabilization stuff, but they use it a ton at Champion, right? And it's not something I learned much in school, and I think it's very specific to basically Wilk, Reinhold, kind of the Birmingham crew does a lot of this. I didn't realize the value until I dislocated my own shoulder. Then I thought they were tremendous rehab exercises, and they were very, very beneficial, particularly once you get to the stage of rehab where you're trying to get in those same positions that used to be very unstable and starting to challenge yourself in those positions. I think they're just really great. They're very helpful.
Awesome. Yeah, I know. Sometimes going through the experience, you finally are like, oh wow, that makes a lot of sense why we do that. Getting injured helps be a better PT sometimes.
Always.
Yeah, and then the seventh key here is they focus on the pre-morbid activity level. So what is the patient's primary goal? What are they trying to get back to? And then, this is, I think, the most fun part of PT is just kind of bridging that gap from where they are when they come to see you and what does their end stage activity look like? What are they doing on the field? So, if this is someone who's trying to get back to jujitsu, that seems like a perfect example of like very unpredictable things happening to the shoulder. Some predictable things, they probably need strength in all types of directions, but they also probably could benefit from, like we were just talking about with the neuromuscular reeducation. They could probably benefit from that type of treatment work in different ranges of motion too, because it's completely unpredictable versus someone who, say is a baseball player. The demands are very predictable for the most part. Aside from maybe sliding where they're unsure how they're going to land when they're sliding, but the throwing motion and the hitting motion are pretty predictable. So we want to make sure we hammer some motion, some strengthening and neuromuscular stuff that looks similar to that. And then just to consider criteria-based return to sport testing. So, I wouldn't look at these research articles that say 3 weeks and think, all right, well, 3 weeks have passed. I think the research seems to show that that's an okay time to return. Let's return. I think we want to definitely be criteria-based in our return to sport. So at Champion, we do a lot of range of motion testing. We do a lot of handheld dynamometer testing with the shoulder. I mean, there are even things you can do now on force plates, which is kind of interesting. So, you want to have some criteria, and then you want to make sure that, in certain cases, I think outcome or patient specific questionnaires can be really helpful just to, make sure you're checking all your boxes for return to sport and you're getting them back to the level that they came to see you for.
Yeah, that's good stuff. Just a little note. You had said this previously, and you kind of just mentioned jujitsu. I think that these end stages of rehab, it really helps either A, if you're a physical therapist, know the specifics of a given sport, right? And if you don't, that's okay, but you probably need to have a coach or someone else who really understands the demands of the sport to help you out. And I'm by no means a jujitsu coach or anything like that. I just enjoy doing it. But for me, with a posterior dislocation, things like end range internal rotation can be a problem. So there's a law called Kimura, which basically puts you into end range internal rotation. I know I'm going to have to be there at some point, right, to make sure that I know what it feels like and to make sure I don't dislocate when I'm there. Triangle choke has your arm across your body, which is basically how I got dislocated in the first place. Not with the triangle, with something different. So just slowly returning back to those positions. If anyone's trying to lead me with arm across the body or arm behind the back, I know that I need to be cautious with that. And then I also know that if I find myself in those positions, I just tap really early and make sure that I don't find myself in a position I shouldn't be. But if you didn't understand some of the specific nature of the sport, it'd be really hard to give people that advice. But if you are a coach and understand that, that's a really easy advice. Like, these are the positions you have to be careful with. Let's not do those initially, right? Eventually, you have to try it, probably in a drilling situation, make sure it feels okay. And then maybe you start to incorporate it when you're going more live and doing more active drills. So it does help to have a coach and kind of lead you through that.
Awesome. And we'll just kind of glaze over this because we'll get a lot more into it in the next episode that we're going to do. But they just suggest a phased rehab approach. So, you could very broadly think to yourself, I always think, what's the end stage? So I actually start in my head by thinking about stage 4. What does stage 4 look like? The return to sport phase, and what type of activities do we have to do in that phase? And then I kind of work backwards a little bit. So if phase 4 is full return to sport, phase 3 might be like advanced strengthening that's replicating the sport as much as possible. And we're challenging it in all different, directions with all different activities. Again, we'll get into that more next episode. But phase 2, we work back from there, and then we're kind of considering a little more cautious type rehab. If then we think of phase 1 as like reduced guarding, gentle range of motion, perhaps some isometrics to desensitize the pain, get the muscle going a little bit, predictable rhythmic stabilizations where we're not going crazy. So we know phase 1 for sure. We know phase 4, and then kind of bridge the gap in the other 2 phases. You could have criteria that you want to see to have the patient kind of progress to the next phase. But I think that this is good guidance if you're just looking through this paper to get some idea of progressing through different phases.
All right, so you went over the principles. Now we need some practical recommendations. Last part of this video is going to be 6 keys to shoulder instability physical therapy. Grab your popcorn. This is the last part. Enjoy. 6 keys to shoulder instability physical therapy rehabilitation. Number 1, are they actually a candidate for physical therapy? Number 2, the direction of instability. That's going to dictate the exercise that you choose. The degree of instability, which is also going to dictate where you start your exercise and how hard you push them. Number 4, we're going to talk about the rotator cuff. That baby is very important for these folks. Talk about restoring proprioception, which is number 5. One of the big things folks lose after shoulder instability, after dislocation. And lastly, getting specific. So returning back to sport or whatever activity that individual wants to get back to. Anything to add, Kevin?
No, that's all good stuff. I think it's going to be a good layout and hopefully, very helpful for our listeners to go through and figure out how to design a rehab program for these folks.
I agree. Well, hopefully we'll see, right? You guys be the judge. Let us know in the comments. If it's garbage, then let us know or don't tell us, but tell if it's good. It makes us feel good. Just kidding.
Yeah.
Tell us everything. We want it all. Number 1, is your patient a good candidate for physical therapy? We already hit this quite a bit. I just think it's super important. So if you take away anything from these podcasts, I think this is going to be one of the most important points, right? Is this actually an ideal candidate for physical therapy? There's a lot of things to think about. So does the individual in front of you, have they been dealing with subluxations where the shoulder's been moving, pops out, comes right back in again? Or have they had dislocations, which are probably going to have Bankart lesion, bony pathology, potentially rotator cuff pathology associated? Those folks maybe need more surgery, whereas the person who has subluxation, it's going to be more of a multi-direction instability, and they're going to do better with physical therapy. Do they have any concomitant pathology? Like I just said, if you fully dislocate, probably have a Bankart tear, right? Which probably is going to need some sort of surgical fixation. Is there any bone loss, any cuff involvement, which these things are also going to dictate whether or not you need to have surgery? What type of instability do you have? And we didn't talk about this much, but there's a little bit of research looking at anterior versus posterior instability. And what they'll find is the folks with posterior instability tend to do a little bit better conservatively, whereas the folks with anterior instability tend to have more recurrences and things like osteoarthritis over the course of time. So if you have posterior instability, you might be thinking more physical therapy, where if it's anterior, maybe referring back to the surgeon a little bit sooner. The other 2 types are multi-direction instability as well as acquired instability. And these 2 tend to do better with physical therapy. We're not pushing them to surgery right away. The other one that's interesting is age. So generally the cutoff is going to be under 30 or over 30. So if you're over 30, you're much less likely to have recurrences. If you're under the age of 30, you're more likely to have recurrence. If you're very young, you're even more likely to have recurrences. So if you have an older individual, sometimes we don't think about doing surgery, but younger, it's definitely on the forefront of our mind. Quick little anecdote. I had a patient that had like almost a 360-degree tear of his labrum at the age of, I think, 52. And he got an opinion. The doctor's like, you definitely need to have surgery for this. And then he got a second opinion to one of the surgeons we really like locally. And the second surgeon's like, let's let this thing scar down and see how it does, right? And what's hilarious is that he did great. He had no problems whatsoever. So even if they do have a lot of pathology with a dislocation, if they're advanced in age, not trying to get back to too much or laying down that stiffer collagen, it might do very well. And what's also interesting is that this individual also felt very stable too. So when I took him to end range external rotation, extension, flexion, it felt stiff. It felt like he had actually stiffened up quite a bit and had a lot of stability there. So just kind of interesting little story. Next thing to think about is activity level. Do you have an individual that's trying to get back to a contact sport like football, where they have a much higher recurrence rate, or do you have a librarian that's just trying to put books back in the shelf, right? So someone who's not involved in a contact sport and someone who's not in a sport at all is probably going to be less likely to need surgery. And the last one is recurrences. Have you had just one dislocation or have you had many? Right. So if you have one dislocation, you have a better chance of rehabbing conservatively. If you have multiple, there's a chance it's going to continue going over the course of time. Right. The big risk there is that if you don't have surgery and you have more recurrences, you can have more damage each time you recur. So you can have bony damage. You might have rotator cuff pathology, rotator cuff tearing that occurs. And then you have a greater chance of future osteoarthritis. So make sure that these things are in your mind when you have a patient with instability. At Champion, we're direct access. We see a lot of folks for the first time. They didn't see a doctor yet. So I want to make sure that we understand these principles to make sure they get the right care, right? And we were just talking about this before, but not other doctors and medical professionals are up to date on all of this information. So sometimes the doctors are not giving their patients great information. So just make sure that they have this information and you send them to a good doctor they can really trust and who knows their stuff, okay? Anything to add there? I just went crazy.
That was really good. I think what popped into my head was just kind of that age old like trope of it depends. I think it kind of there's no clear answer. There's so much to it. And I think when you're first meeting the patient and you're going through your subjective, every question that you're asking has to have, it's telling you something. It's telling you more about the patient. It's telling you the mechanism of injury, the direction of instability, and their age, and all that stuff is part of the algorithm to help us figure out what to do. Is this someone that we need to refer out? Is this someone that we need to, we could try to keep in house? Definitely an it depends type situation, but having all these key questions that we've gone over will help you make a better decision in the clinic for the patient. So yeah, I think that was good.
Agree totally. We also did a whole podcast on this, and I'll leave a link in the show notes. You guys want to check that out when we're trying to decide whether or not your patient should have surgery or not. I think that's also a good episode. I'm biased just because I'm part of the podcast, but I thought it was good. Cool. Number two, second principle is going to be the direction of instability, right? So this comes back to rolls and glides of the joint. So kind of going back to PT school to try to figure out the direction of instability and what kind of movements you have to be careful with initially. It also relates back to that mechanism of injury. If you have anterior instability, anything that pushes the ball forward or anteriorly in the socket, you have to be careful with. So the motions of external rotation, horizontal abduction, and extension will push the ball anteriorly in the socket. So early on, you have to be very careful with those end ranges. So you're often doing a lot of partial range of motion stuff. However, we can probably get away with end range flexion, potentially. We can probably get away with more cross body work. We can get away with more end range internal rotation just because the instability is going to be in one direction. So it helps to guide you in terms of which motions are going to be important. And we'll talk about this a little bit later, but if someone has anterior instability and they need to get back to horizontal abduction, external rotation, we have to really hammer those positions and get incredibly strong there, because now you're probably lacking capsular restraint, or if you stretched out that ligament quite a bit, if it's not torn, right? We need to be super strong in those positions. So early on, starting with partial range of motion, and later on, we have to get extremely strong at end ranges that were provocative initially. For the posterior instability, these folks are going to have trouble with end range flexion, which will stress the posterior and inferior capsule, internal rotation, and also cross-body horizontal adduction. All these motions are usually where people get hurt in the first place, right? And they're also the places you have to protect early on and then really strengthen in the end stages. For folks who have multi-direction instability, they're probably loose in a variety of different directions. So I think what's important for these folks is that you're just careful with the end ranges that are provocative initially, And then at the end of their rehab, we have to get back to those positions and anything that the athlete wants to get back to specifically. So let's say they want to be back to snatching, they need to get really stable, end range, abduction, external rotation. Those motions are very important because we see that when you catch a snatch, right? So to summarize, we're avoiding the ranges that are provocative initially due to that instability event. And then eventually we got to get really, really strong in those positions. What do you think there, Kevin?
I think that's a great way to think about the rehab process, right? So if you figure out on your initial evaluation what direction of instability they had, and then when you're going through your testing, it's confirming that, they had anterior instability and they're pretty apprehensive in that extended shoulder position or kind of in that external rotated position where we know the humeral head's gliding anteriorly. Those are positions we really want to hammer towards the end of rehab. So almost think of like a clearance for return to sport. Are they now more comfortable in these positions that were once very provocative? So I like the way that you were thinking, that you think about that is early on, let's respect that tissue, let it heal, let it scar down. But then as the rehab process goes, we have to slowly dose that stuff in and then really kind of hammer it and make sure that they're comfortable there.
Yeah, agree. The other part too is that if you get the end stages of rehab and they're just really not tolerating those end ranges, you've tried a lot, it's not improving, then maybe that's the patient you end up sending back to surgery just because they just kind of failed the conservative treatment. Next step would be some sort of surgery, right? Number three, degree of instability. And I think largely what this comes down to is how bad is it? Now, a lot of times this is going to come down to what you're seeing in the MRI. So, how much tearing is there? Is there going to be bone loss? So on and so forth. But I think the other piece is just how do they present, right? Because you are not your MRI, right? Your MRI may show something, but you actually move quite well. So, a lot of this, I think, comes down to the subjective and objective examination. So asking them which positions feel unstable, and they'll kind of show you probably. They'll say, "Oh, it kind of feels a little unstable when I go into this position," and you're kind of like, "Whoa, whoa, whoa! Don't dislocate your shoulder on me." But they'll kind of show you, and they'll tell you which positions they feel unstable. And for someone that has anterior instability, for some folks, they really can't do much of anything, and they start feeling very unstable. And other folks have quite a bit of range of motion, right? So you'll tease out a lot of that in the subjective examination. And then when you start doing the objective, you're just going to get more and more information. And I always go very slow when I'm doing the range of motion testing, but going into flexion slowly. Do you feel instability? Yes or no? And then where, right? And then just see where they're at on the other side. Are they getting instability end range or are they getting, instability 50% through that range of motion? I think those are actually pretty good objective measurements to test throughout the course of the rehab, see if they're having less and less instability as we progress further along. We're not just like cranking them into layback and saying, "Does this feel unstable?" Like, yeah. And then like 2 months later, you do the same exact thing and it still feels unstable. They may have gotten better. It's just that we don't know how much because you never got a good reading from the beginning. So I think that's a little clinical pearl that you can take with your patients. And the other no-brainer thing to start with is going to be partial ranges of motion. So let's say someone has anterior instability and I still want to take them into the gym and test that stability with, let's say, a bench press. So when you do a bench press, you go into shoulder extension, which is going to drive that humeral head forward into the instability. I want to go slowly. So maybe I start with a partial range of motion. How does that feel? Let's go a little bit deeper. Does it feel okay? Feels great. Okay, let's try full range of motion. If they start with partial range, how does that feel? Let's go a little deeper. Doesn't feel good. Feels a little unstable. Okay, let's start with that partial range of motion. And that kind of brings us to our next point is that really what you're doing is trying to meet them where they are, right? And I really like the phase rehab approach. We talked about this a little bit in the last podcast. Phase 1, phase 2, phase 3, phase 4. And I think that's a really good framework. It's a great way to learn it. But in reality, you're going to have people that kind of come in at all different stages. And that might be because they had a fresh injury or they're a couple months out, right? Or just the degree of instability. I'll tell you what, when I had my posterior dislocation, almost immediately I could do everything in the gym, right? Which speaks to that degree of instability. There were certainly certain positions I couldn't tolerate, but I could do bench press, pull-ups, rows. I could do everything nice and heavy. Really nothing gave me a lot of trouble unless I got into very specific positions. So if I had started with like only, let's say, external rotation, a partial range, and like scaption, and that was it, I might have been underdosing myself, right? So at the end of the day, you're trying to figure out what can this person handle. Obviously, you got to be safe, but we want to make sure we don't underdose and we want to make sure we don't overdose. So we take them in the gym, we try some things, we try activities, and we just kind of figure out where they are and try to meet them where they are. Right. What are your thoughts there, Kevo?
Yeah, that's such a good point. I think that's something that you do so well in the clinic is someone has, say, anterior instability in this example, and we know we're going to do some conservative rehab, and we're going to avoid things early on or modify something like a bench press where we know we're stressing the anterior capsule. But I think you do a great job of taking them out to the gym and figuring out what's the highest amount of activity that they can tolerate. So if there was no damage to their posterior capsule, they might feel great doing some rows as long as they're not, kind of dipping and stressing the anterior capsule at end range, but they can still get a very high training effect oftentimes if the groove instability is pretty low. So, we don't want to just think that they're very unstable anteriorly. So we have to stay on the table and do these very, very gentle open chain exercises or isometrics. Although that might be the right place to start for somebody, getting a good read on what the degree of instability is and getting a good read on their goals. And, I know someone like you, if you were my patient and I said, Dan, we're just going to do a bunch of isometrics and gentle range of motion, you would be itching to get back into the gym as soon as possible. And I'd probably lose you as a patient. So, or you'd probably just go do a bunch of things and maybe risk re-injuring it on your own. So I think, figuring that out and trying to have them do as much as possible to keep their normal routine is going to be huge for them. So I thought that's a good point.
Yeah, that's the first thing I thought. If, I would probably just go in the gym and try a bunch of stuff myself, and I would do my rehab on top of that.
Exactly. Yeah. And I think a lot of patients that we get are like that. They're very self-motivated. They love exercise, and taking everything away if we don't have to is like one of the worst things you could do.
Yeah. Yeah. But the other
And they
part too is you got to be safe, right? I think there are some pretty dire repercussions of this. Something like a rotator cuff related pain, rotator cuff tendinopathy, subacromial pain. I think to steal a term from Chris Johnson, you can be a little more cavalier, right? You can do more with it. And, worst comes to worst, you're a little extra sore for a few days. You set yourself back some. Um, worst case scenario with anterior instability, you redislocate, right? In the gym, doing stuff that's supposed to make you stronger, right? And rehab you. So I still think you have to be careful with this. But I also am of the mindset that we should be trying to exercise our patients as much as possible. We want them to be outside of the gym for as little as possible. Obviously, there's so much health benefit to being in the gym. People love it. They're going to love you as a physical therapist if you can figure out a way to have them continue doing the things that they love. You're going to create healthier, happier people, so on and so forth. I'll get off my soapbox right now. It's probably annoying. But yeah, try to keep people in the gym doing stuff that they can do. I think that's also going to help them from a rehab perspective, because I can't imagine, if they if they can tolerate some heavier pressing, it's not going to be beneficial to build some stability in that shoulder joint, right? Over just sideline external rotation, which we also love, obviously. Number 4, hammer the rotator cuff. So, Kevin, do you think the rotator cuff is important for the shoulder?
No, I think isn't it like an accessory structure like your appendix?
Yeah, it's
It's
like a
not.
platysmus, used to serve a function, or like your appendix, right?
Yeah.
Don't really need
Yep. I
it.
think it's slowly fading out of evolution. I don't think we need it much.
For sure. Yeah. Kidding aside, I think the rotator cuff is probably the most important structure for these patients, that you really, really need to focus on it early on, especially. And I think isolating it early on is going to be very, very important. I imagine there's probably going to be some inhibition. So if you think about someone that had a patellar dislocation or they had ACL reconstruction surgery or something along those lines, there's a ton of inhibition to the quad. Same thing is probably happening when someone has a major injury within their shoulder joint. We just can't really see those muscles, right? Someone has Achilles repair, the calf gets tiny. Someone has ACL reconstruction, the quad gets tiny. Someone has rotator cuff repair or a major shoulder surgery, the cuff is getting smaller too and weaker. You just can't see it, right? So I do think that the cuff is kind of like the quad, although I don't have a ton of research to support that. I know there's some, right? But I do think it's very important that we focus on the rotator cuff, because after a major injury, I bet you it's not working as well as it once did. And the second piece is now you're missing that as a primary, you're missing some other primary restraints of the shoulder. So if you think about what restrains the shoulder, the first are the bony restraints, right? So you have the humeral head and the glenoid. And it's funny because we always talk about this structure being very unstable. And if you compare it to the hip, it is, right? But through our research, we know that the more glenoid you lose, the more likelihood you have of redislocating, right? So the little bone that you have is very, very important. So if you start to lose any bone, so much so that if you're above, let's say around 25%, it's almost like a absolute indication to get surgery for this, we're going to be less and less stable, right? The other piece is that if you're having an anterior instability dislocation, then you're probably tearing the inferior band, or excuse me, the anterior band of the inferior glenohumeral ligament. So you've most likely torn a major support structure within the shoulder. Now, what do you have left over to control motion? Well, essentially, you have the rotator cuff. So that's the last thing that you have that's providing stability within the joint. So now the rotator cuff has just gotten way, way, way more important. What are your thoughts there, Kevin? Because I'm talking a lot. I want to give you a chance to say some stuff if you have anything.
Yeah, totally. I mean, that's definitely the biggest focus that we have with our instability patients. We see a lot of that acquired type instability just with the overhead athletes that we treat. And I think, specifically with baseball, we know that throwing is stressful on the rotator cuff and it can reduce strength over the course of the season in your rotator cuff. And then you take someone who starts to lose their strength in the cuff that's providing a lot of the stability. Yeah, so perhaps these players have a lot of acquired instability from years and years of throwing, getting back into external rotation, and the capsule becomes compromised. And strengthening the rotator cuff there is super important, and it's something that we do very often. And it's something that we test regularly. We try to get objective testing and make sure that we're heading in the right direction. So I think, the person in front of you can feel they're getting stronger, they're progressing their weights in their exercise program, but also doing some dynamometer testing is helpful, I think. I have a question for you, though. I'm curious what you think about in terms of dosing for strength, the rotator cuff. So if we're doing something with these, smaller muscles, I think it's pretty typical in a lot of outpatient PT settings that you'll see people doing exercises with a TheraBand, or they're using some weights and they're doing something like 2 or 3 sets of like 10 or 15 repetitions. What do you have in mind when you're trying to strengthen these folks? Because, I think you do a good job with this. Are you thinking of something like, do you do higher reps with these smaller muscles? Are you thinking of going with an intensity of like a reps in reserve type thing? Or are you happy doing what you do with a lot of other strengthening and doing a little bit lower reps for higher weight? I think, how do you think about that?
Yeah, so I think early on in rehab, we're probably thinking about tolerance first. And what I mean by that is that we're starting with easy stuff because we don't want to aggravate the joint too much. We don't want to create more pain, more swelling, perpetuate a problem that's already going on. We kind of want the opposite. So I think early on, I think more of neuromuscular control as well as just tolerance. So we're trying to get to the point where people can tolerate more loading. So if we're thinking about, let's say, a sideline dumbbell external rotation, first and foremost, I think it's usually tolerated pretty well. But we'll start with slightly higher repetitions and lighter loads just because we want to make sure that it's not too provocative, simply because higher loads, higher weights tend to be a little bit more provocative. And I might actually program a lot of repetitions throughout the course of the day, just as we're trying to reestablish control. The way I kind of explain this to patients is that if you're like a painter and you want to get really good at painting, we want to try to paint very, very frequently to develop the skill of painting. And I think when we're trying to establish neuromuscular control, if we do a lot of repetitions, we're reteaching the muscle how to fire appropriately, right? When it comes to strength, I think, fortunately for us, it's pretty similar. I think you start using a little bit more weight, right? So we're just using more weight for sideline external rotations. We're going to the point where we're starting to approach failure, right? Lots of really interesting research coming out recently. I won't get too far into depth, but if you're training, let's say 4 to 6, even up to 7 reps in reserve, you're getting a similar training effect as approaching failure. And sometimes when you hit failure, you're actually getting a worse strength training effect, depending on the study that you reach. So usually now what I've been doing when I talk to patients is when I want them to start approaching failure and I'm choosing somewhere in between the rep range of 10 to 12, I'll say, let's keep 4 to 6 reps in reserve, because I think that is reflected in the literature we have about how to optimally push strength, right? You just have to be careful that if you go heavier, 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 it doesn't aggravate the shoulder, right? The other obvious thing I think you can do is you can start to drop the repetition some. So you can start going from sets of 10 to 12 down to 6 to 8, right? What I will say is that I'm not really going much below, let's say 5 for sideline dumbbell external rotation, but I will start approaching that rep range for something like a bench press over the course of time. And I think the last variable that you can tweak a little bit from a strength perspective is going to be frequency and volume. So they're kind of one and the same. So if you're doing more volume and splitting it up over multiple days, that's more frequency, right? But we do have research to show that the higher the frequency is, the greater the strength gain, right? So volume seems to be king from a hypertrophy and strength perspective. Just the more often you're doing something, the more strength and muscle mass you're going to build, probably. There's certainly going to be diminishing effects, but now we're finding up to like 52 sets of an exercise per week. Every set increase just keeps on going up and up and up from a hypertrophy standpoint. So you just have to be careful not to flare someone up. But if you're trying to build strength, obviously you can drop the repetitions. You can do the motion a little bit faster, right? You can increase the load. You can lower the rep in reserve, and you can do the exercise more frequently. All those things are going to be beneficial ways to increase strength.
That's awesome. Yeah, I wasn't aware of that 4 to 7 reps in reserve. So that's good to know. And
Yeah,
I think that's
I mean, that's one of the best pieces of news I've received in a long time, because I'm constantly trying to keep people strong and reduce the load they're training at because they can't tolerate it. And if I can just drop the rep in reserve and you're going to continue increasing your strength the same exact rate, I don't know. I tell people about that study all the time. They
yeah,
probably
that's
think I'm
awesome.
crazy because like, this is stupid. Like, this isn't relevant. But in my world, it's incredibly relevant. So
Totally, totally.
another thing to think about with instability, and this becomes really important when you're talking about return to sport and keep people safe long term, is that if you have anterior instability, the primary restraint to the ball moving forward in the socket is going to be the posterior cuff. So we work with a lot of baseball players and they acquire anterior instability. So we go bananas on the posterior cuff. The posterior cuff is so important. And Kevin already spoke about this, but we're trying to test external rotation strength, and we're constantly looking at that number over the course of time to see if we're progressing, because we know that's going to be extremely important for these individuals. However, if you have a posterior instability patient, you probably want to try to stress the anterior cuff a little more so, right? We usually think posterior cuff, posterior cuff, posterior cuff. Well, if you have a posterior instability, then basically your anterior cuff is going to reduce that posterior translation. So in theory, the anterior cuff is going to be a little bit more important. So for a guy like me who has posterior instability, I'm constantly working on my anterior cuff a lot. I'm getting my subscap as strong as possible. I tell folks in the gym that I'm trying to prepare for an arm wrestling tournament when they ask me weird questions about what I'm doing. Just kidding. I don't do that. But you can think about that direction of instability when you're applying exercises. And when you get to higher level exercises and the person's getting back to sport, we really have to train that cuff in that specific position, because that's going to be the primary restraint to another instability event. Number 5, restore proprioception. Now, this one, I think it should be a little more obvious than it actually is. So when someone has like ACL reconstruction, or maybe even more obvious, when someone sprains their ankle, we are so concerned about restoring proprioception. We have those people on balance boards. We're tossing balls at them. We got the blaze pods going. We're doing perturbations. We're doing like every balance exercise in the book, right? But when someone has instability, we're not always thinking in the same way. But we have pretty clear research to show that after people have a dislocation, if people have capsular laxity, or after they've had a surgical fixation, so a Bankart repair, they have reduced proprioception. So I think that's a really important element that we have to focus on from a rehab perspective, right? In terms of what interventions we have, I think it's pretty obvious when you think about the lower extremity. We just do a ton of balance exercises. But what do you do for someone that has instability within the shoulder joint? Well, for one, I think you can do the same exact thing. You can do closed chain exercises on an unstable surface. You can do all sorts of different things with that. So, in a push up position on a wobble board, you can have them try to reach in different positions while you're balancing in one hand, all sorts of stuff you can get creative with, right? You can also do a lot of eyes closed work. So essentially, any exercise you were doing with your eyes open, you just do the same exact thing with your eyes closed. It's kind of wonky, but if you're doing, let's say, a bench press, your eyes open, you can really easily tell where that barbell is in space. As soon as you close your eyes, things get very unstable and it's hard to control those. Another thing I didn't write on here is that you can use unstable implements. So if I was to do, let's say, a dumbbell bench press, if I switched out the dumbbell for a kettlebell, bottoms up press, it's very unstable. That's a great way to train. When I had my instability within the shoulder, I used an earthquake bar or a bamboo bar, and I attached bands to the end and attached weights to those bands. So essentially, the bar is earthquaking, right? As the name implies, shaking like crazy. Shoulder joint has to work like crazy to stabilize that motion. I felt like I built a ton of stability within the joint there. And the last piece that we work on a lot is rhythmic stabilization. Kevin, do you want to talk about our rhythmic stabilization program at Champion? Because I know you do this all the time, every single day. I do it too, but I know you do it a little bit more.
Yeah, so the way that we kind of organize that is, after we're on the table doing some passive range of motion, just assessing, seeing how things are, we like to do like a 6 position rhythmic stabilization sequence. So if you picture someone supine, we bring their arm to about 45 degrees of flexion. So arm straight, about 45 degrees of flexion. And we do rhythmic stabilizations, and that amount of flexion, we go up to 90 degrees. We go up to about 120 or more up to end range when they get better. And then we also are doing external rotation at 90 degrees of abduction. We're doing external rotation with 45 degrees of external rotation and then all the way back and lay back. And then we're kind of really working the shoulder in a bunch of different directions. For folks that have more like a posterior instability, we could do that in some internal rotation. We can bring them cross body. We do eyes open, eyes closed. So, obviously when we're first starting, we do pretty predictable eyes open type, almost like isometric work. But then as they get more and more comfortable, I do have them close their eyes pretty early. I mean, we make that like a later phase, but I think that's kind of important for folks to, like you mentioned, when you can't see where the resistance is coming from, you're really using that reactive stability to figure that out. So, and then we can do that in different amounts of scapular protraction. So we'll have someone kind of punch up towards the ceiling, and now they're getting a little bit of accessory from their serratus and doing rhythmic stabilizations there. So, you can make this pretty aggressive. Obviously, we start out maybe 5 or 10 seconds each position. But then as they get better, I might spend a little more time there, alternate eyes open, eyes closed. Um, and it's fun. It's fun for the patient. They kind of feel like it's a game. It's fun. It's fun as the PT to see their progression over time. Early on they could be very, very wobbly, but they might progress. They might progress pretty quickly, and I think that's good. So for people that might need a visual for that, I know Mike Reynolds' YouTube channel, I'm pretty sure he's posted about 6 position rhythmic stabilizations in the past. So, he has great content on that. And, I think Mike or Kevin Wilkes' Instagram definitely has some. I'm sure there's some somewhere in the Fitness Pain Free Instagram. So, yeah, we utilize that a ton. And, that's from stuff we've been taught, for me, stuff I've been taught from Mike and Lenny. It's been really helpful for my shoulder patients.
Yeah, I'll put a link. I have some more advanced ones I have that I like a lot. I can put a link if you guys are kind of interested in what they look like. But just to, Kevin nailed it. Like I learned it from these guys. I'm stealing it directly from them. So go check out Kevin Wilk and Mike's stuff. They have a lot of really good content, Instagram, YouTube, where they show you about these rhythmic stabilizations. Number 6 is getting specific. And this is usually a little bit later on in terms of rehabilitation. So early on, you're trying to calm things down a little bit, restore range of motion, restore baseline strength. Eventually, they're going to get closer and closer back to their activities. And depending on what they want to get back to, you may have more or less of a tall task, right? So if someone wants to get back to rugby, that's a lot, right? We know that they're going to have to tolerate end ranges of motion. They're going to have to tolerate end ranges of motion with fast forces. Their arm's going to get ripped back potentially. They're also going to have the risk of falling with the arm behind them, right, in the same exact position. There's a lot of positions that that individual is going to have to handle with high forces, high speeds, all that stuff, right? So we really have to work on getting very strong and very stable in all of these positions. And that's really going to dictate whether or not you think they're safe to get back. And basically, you get an idea of how likely they are to have recurrence. If they feel very stable, very strong in those positions, athlete is very confident in their shoulder, I think they're going to have a better result than if they're trying to get in those positions. They just feel super wobbly. First time they get into that position with high speed, high load, I just don't know if that shoulder is going to handle it very well, right? We talked about this already, but baseball players, what do they need to get back to? So if they have anterior instability, they're going to notice those symptoms in layback. When we're really cranked back into external rotation, that's the position where the anterior structure is going to be most challenged. So we have to make sure that we really build that back up over the course of time, and then we slowly ramp back into throwing. So I think Mike Reynolds probably got one of the best papers on return to throwing. It was just released. Do you remember what journal that was in, Kevin?
I think it was in IJSPT.
That's what I was going to say too, but I might be wrong there. Maybe we'll try to throw a link in the bio there or link in the description. But yeah, we have a very gradual return to throw program, very evidence based. Mike just released a paper on this, which is phenomenal. A champion, I think we have like 75 return to throw programs, all based on like what injury you've had, what position you're playing, all that stuff. A lot of that's beyond me. I pick a program, I talk to Lenny and make sure I'm not doing anything stupid. But the idea is you're starting with less and you're working up to more over the course of time. And then you also might be dealing with an athlete that is trying to tolerate a very different type of stress. And I think a good example that I work with all the time is going to be Olympic weightlifting. So think about a snatch. You're taking a weight from the floor, maximal load, throwing it overhead and catching it in extreme end range shoulder abduction, right? For someone that has anterior instability or multi-direction instability, that's a pretty darn tough position for the shoulder to be able to handle. So we have to very, very thoroughly strengthen that position, provide a ton of stability there, and then slowly ramp back into the Olympic lifts over the course of time, just to make sure we don't have a bunch of recurrences, right? What do you think about that one there, Gavin?
Yeah, that's all really good stuff. I think the one thing I try to really focus on when I evaluate a new patient and something I talk to the students about is figuring out what their end goal is. And, that's really, really important because a lot of times students will have trouble figuring out where to start treatment. But I think if you work your way back from the end goal, for me, it makes it a lot more clear where I should be starting and where we're heading. So it gives the treatment progression some sort of like a roadmap. So I think everything you said there was great, and I think that's how I would use that information. Is I would try to learn what we have to get back to, and then try to make our rehab uh, trend towards that as we progress over time.
So now that Kevin has thoroughly educated you on 6 keys to rehabilitation from shoulder instability, you probably need a little case study to see what we're talking about. Well, I have a link for you. It's going to be over top of Kevin's head right now. Oh, right up there. Yep, click on that. Where we go over case study of a patient of mine that had multi-direction instability, and she really wasn't able to do much due to pain and feelings of instability. We rehabbed her all the way back up to high-level CrossFit. So go ahead and click on that. It's a case study. I'll show you exactly how I did it. I'll see you in that video. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.